Hello, my name is Tehmina Mustafa and I'm a professor of international health at University of Bergen. I will talk about the treatment of tuberculosis. The objectives of this lecture are to become familiar with the first-line anti-tuberculosis drugs and the standard treatment regimens, also the principles of treatment, and also to identify the common adverse effects. More detailed information about treatment of tuberculosis can be found on the guidelines published by uh, WHO and other relevant literature as mentioned. Uh, the goal of tuberculosis treatment is to ensure a relapse-free cure while preventing the emergence of drug resistance. The effect of treatment should therefore be judged not by the anatomical healing of lesions, but actually by their sterilization, or at least by the elimination of bacilli from the sputum in case of pulmonary TB. Mycobacterium tuberculosis is a slow-growing anaerobe organism, but can remain dormant for a prolonged period of time. Consequently, prolonged treatment with multiple drugs is required to ensure a relapse-free cure and to prevent the emergence of resistance. The effect of treatment is determined mainly by bacteriological, environmental, and pharmacological factors. The number of bacteria varies widely with the type of lesion. For example, in case of lung TB, the number of bacilli in a medium-sized cavity communicating with the bronchi is about 10 to the 8 bacilli, about 100 million. Whereas in an encapsulated nodular lesion of the same size with no bronchial communication, the number can be as low as 100. The numbers are also low in extrapulmonary lesions of, for example, lymph nodes, pleura, meninges, bones, etc. The larger the bacterial population, the higher is the probability that mutant strains are present even before treatment is started. And monotherapy can lead to selective growth of these resistant mutants, leading to the development of drug resistance. Also, drugs kill organisms that metabolize actively and multiply continuously. But in each bacterial population, there are bacilli with a very low metabolic rate. In case of TB, some bacteria are also inhibited owing to a low pH, and others are dormant most of the time and grow, if at all, only during short periods. Prolonged treatment is required to kill these bacteria, which are also generally called persisters. There are some important considerations to be taken before treatment. For example, whether there's known or suspected possibility of presence of drug-resistant strains, and this is done by taking history of prior treatment with anti-TB drugs, because prior treatment could enhance the possibility of finding drug-resistant strains. Also, country of origin is very important, especially in case of immigrants in low endemic settings. Uh, Location of disease is important, even though standard treatment is 6 months for most forms of disease, pulmonary and many forms of extrapulmonary disease, but some extrapulmonary conditions may require longer treatment period. Also, one needs to look at the likelihood of adherence to treatment, and if there is a and to take measures which can increase the drug adherence, and also what is the likelihood of adverse reactions, and also what are the comorbidities and what is the status of host immune response. Um, People who are immune compromised are more susceptible to have adverse reactions. This slide summarizes the anti-TB drugs available. Streptomycin was the first effective anti-TB drug, which was discovered in 1944. It was followed in 1949 by discovery of para-amino salicylic acid, and these two drugs were used in combination for quite a period of time. Until in 1952, anti-TB activity of isoniazid was discovered, and this isoniazid is one of the main anti-TB drugs used in treatment today. The most effective drug, rifampicin, was discovered in 1960. And today the commonly used combination is isoniazid, rifampicin, pyrazinamide, and ethambutol. Rest of the drugs are used only if resistance to one or many of these first-line drugs are documented. The standard treatment regime is to use 4 drugs for 2 months in the initial intensive phase. This combination is usually isoniazid, rifampicin, pyrazinamide, and ethambutol. The advantage of this combination is that this quickly kills the rapidly dividing bacilli and thereby controls the disease. It also renders patients non-infectious and prevents the emergence of drug resistance. In the continuation phase, which is continued in 4 months, the 2 drugs are used in combination, isoniazid and rifampicin, and the main purpose of this continuation phase is to kill the dormant and semi-dormant bacilli, which are also called persisters. And the use of this continuation phase or long-term treatment is to prevent relapse. The mechanism of working of these different anti-TB drugs varies, and therefore they have a synergistic effect leading to the sterilization of lesions. Isoniazid and rifampicin, they are bactericidal against rapidly dividing bacteria. Isoniazid inhibits mycolic acid synthesis, while rifampicin inhibits RNA polymerase. It also has the ability to penetrate into the fibrotic areas, therefore kills the semi-dormant organisms, which are not reachable by other drugs. In fact, it is the addition of rifampicin which has led to a relatively short duration of treatment. Without rifampicin, treatment course needs to be prolonged to 12 to 18 months. Pyrazinamide kills semi-dormant bacteria in an environment of low pH, while ethambutol is basically used to prevent the emergence of rifampicin resistance when primary resistance to isoniazid may be present. While patients are put on treatment, it is very important that they should be followed up regularly under treatment. Patient should be explained properly the treatment regimen, and they should be monitored for adverse reactions, which goes both by recording the symptoms and signs, and also doing the biochemical analysis of blood. For example, symptoms of hepatotoxicity, it does not appear, and it is important that regular mm, liver function tests are undertaken. Um, Also, it is very important to assess and ensure adherence to treatment. All the treatment containing rifampicin is given as directly observed therapy, where another person makes sure that patient has taken the drugs as recommended. Regular follow-up is important to evaluate the treatment response, which is done by recording symptomatic relief and also microbiological response, which is possible in case of sputum positive pulmonary TB, where there should be a sputum examination done at 2 months, and in case of successful treatment, this sputum sample at 2 months should be negative. Radiological response should also be checked at 2 months and at the completion of therapy. However, it can take longer to get a radiological for the regimens containing ethambutol. Baseline vision test is always done. It is very important that patient gets information about the long-term treatment and the potential side effects. Public health workers who have regular contact with the patient should always ask actively about adverse reactions, and monthly evaluation by clinician during treatment and is also important. And during these follow-up visits, the main concern is to assess the response to treatment and the side effects. And this slide shows the most common adverse reactions to TB drugs. All the TB drugs, they can give allergic reaction, and most of this common sign and symptom of this reaction is skin rash, which can be serious and could lead to interruption of treatment, but in most of the cases this is mild rash, and it can resolve without any medication, or sometimes one needs to prescribe local and local steroid treatments or anti-allergy medication. Ethambutol could lead to blurred or changed vision, or it can also affect the color vision, which is also quite serious. Therefore, a baseline eye test is always done. Isoniazid, pyrazinamide, and rifampicin, all three can give hepatitis, inflammation in the liver cells, and it usually this is asymptomatic. Therefore, it is important to have baseline blood tests, and in case of increase in the liver enzymes, appropriate measures are taken by the clinicians. All these signs and symptoms mentioned here, they come quite late in case of quite advanced hepatitis. Isoniazid can lead to peripheral neuropathy, which can lead to tingling sensation in hands and feet, which is quite a serious side effect. Normally, pyridoxine tablets are given along with the anti-TB treatment, which usually prevents this side effect. Rifampicin can also lead to um, bleeding problems due to reduction in platelet count, for example, easy bruising or slow blood clotting, which can lead to serious consequences. However, a minor side effect is discoloration of all body fluids. So, for example, if a patient is using contact lenses, they can be stained potentially. Rifampicin interferes with most of the medications because of affection of an enzyme. Therefore, patient medication list should always be checked. Furthermore, it can lead to sensitivity to sunlight, leading to frequent sunburns. And this slide shows results of a meta-analysis of hepatitis frequency associated with the combination of isoniazid and rifampicin. And as it shows that when isoniazid and rifampicin are given in combination, the percentage of or frequency of hepatitis occurrence increases.